So I was asked to talk about the gynae-oncology nursing competencies, and I'm hoping that most of you will be aware that these are now published through the BGCS. And this is stage one of a large project that we've been working on over the last few years. And it is about enhancing practice and inspiring future generations. We're conscious that there is much being written and spoken about in terms of workforce. And somehow along the line, we've got to kind of think about how we're going to protect that for the future, because I think the demands are going to change in relation to cancer care. They're also going to change and become increasingly challenging for our CNSs. So today's agenda, very quick and simple. Why do we need these? What value are they going to add? Are they raising standards? And therefore, how do we inspire the next generations? Are they a tool for that? And then what happens next after that? So quite simply, our aims and ambitions in relation to setting out these competencies are literally to inspire, educate, improve. I won't tell you what my husband said. He said inebriate when he was trying to come up with a third eye, but that's a very typical of my husband, as you can imagine, for those of you who've seen him before. So inspire, educate, and improve. Why do we need these? So I looked at the evidence as, why are we going to actually bother, really? So there is evidence out there to show that obviously competent nurses are key contributors to maintaining safe and effective healthcare services by integrating knowledge, skills, and attitudes that enable them to adapt to dynamic health environments. Nurses are often the primary point of contact with patients and responsible for ensuring that their needs are met. By providing patient-centered care, nurses can help create a culture that prioritises safety. In addition, they can act as advocates for patient safety, promoting a culture of safety within the organisation and encouraging others to do the same. Well, we know that those are key elements of all nursing care, but what they're trying to demonstrate through this article, and you need to read it in its entirety, is that if you don't have the underpinning competencies, you are not going to get the most effective outcomes, nor the best and safest possible care that our gynae-oncology nurses wish to deliver. So we need to have that have the foundation stones. And this first part of the competency document provides 3 levels. So it's foundations in all 5 gynae cancers. And it's an incremental learning across 3 domains, from beginners to leaders. So it's a paced learning program, which we would say takes about 2 years, because we're very, very conscious of the time that is involved in any form of learning, the limited opportunities our clinical nurse specialists get. And so therefore, we don't want to put them under too much pressure. Now, some people may eat it and just do it very, very quickly, but there's sometimes something to be said about doing something at a slightly slower pace, because it just gives you time to bring the practice and the clinical knowledge together. And certainly my new associate I've got on the programme at the moment, and she's certainly finding it very beneficial, because she is new to oncology, that as she begins to do the competencies alongside working in practice, this makes a very big difference to her. So it's enhancing that practice with theory to practice. So what actual value are these going to add? So again, it's fairly repetitive. It's that combination of the knowledge, skill, and attitude just to get that safe and effective care. So knowledge, we know, is obviously usually achieved through education and clinical experience. It's a combination of the two, isn't it? And we all go through that as clinicians, and it's the basis for those skills and attitudes. So it's the ability to use that knowledge in practice, and through frequent use of that knowledge at work, and therefore results in quality improvement and will lead to hopefully quality improvement projects. So again, reiterating, foundations in all 5 gynae cancers, that incremental learning, the pace learning, enhancing practice with theory. And part 2 is currently in preparation at the moment. And this is going to take the form of more advanced skills, because we're conscious that nurses will say, well, that's great, but what happens next? What about our future development? That's all very well and good. So we are working on part 2. Again, it's a large project. Some of the subject matters that we're looking at, and Sarah's talk was extremely interesting. So thank you very much indeed, Sarah, for a brilliant presentation. We'll obviously look at a little bit more in depth about pre-rehabilitation. Sorry, I put my teeth in there. My apologies. and genetics. Now we know there's a lot of information out there, so we will tie things in together with learning that's already out there. But what we want to do for the BGCS and to encourage nurses for the future is to have a fundamental core project document that people can see their progress in one place without having to flit all over the place, go to lots of different courses, and that therefore they can feel that they've completed a fundamental piece of learning that's going to give them the foundations and the advanced skills to be able to contribute really effectively in gynae-oncology, stay within the profession, because we know it's a tough profession. We're covering 5 gynae areas, and emotionally it's very, very tough. And particularly with the stresses and strains that we all experience in the NHS, we want to ensure that. So how are we actually going to inspire them? Well, we're going to encourage them, we're going to incentivize them, and we're going to empower them. Well, there's very little really we can give in the NHS in terms of incentivizations. I mean, we can't give people pay rises, etc., but we can give them time and learning opportunities. And I think it's really important that we look to that in the same way that Sarah was talking about, the importance of the changing dynamics in terms of rehabilitating patients, getting them ready, etc., etc., and that prehabilitation. These elements are very, very important. Whilst we know about them, we've got to think about how do we incorporate all of that within our clinical practice. Do we need to think about different ways of doing it? Do we need to tap into third-party resources, etc.? Do we need to use what's out there to help us deliver these agendas? So we really want to keep our nurses on board. We want to keep them energized, and we want to keep them learning within their own pace. So as Walt Disney said, the way to get started is to quit talking and begin doing. So that really is the simple message. We need to encourage all of our workforce, wherever possible, to start these gynae-oncology competencies in the same way that the IGCS are producing competencies and trying to roll those out. And we're anticipating, I've talked with Sarah at the IGCS, who's my counterpart in the IGCS, about looking at doing something and exploring that subject matter a little bit further, hopefully at the BGCS in the summer, the annual scientific meeting, but that has a little way to go at the moment. So as I said, it was going to be short, sweet and simple. And I just really would like to encourage you. I know we all very much value our gynae-oncology clinical nurse specialists. I certainly value my new colleague and the contribution she makes. And I know as clinicians, we want to work as effectively as we can as a team, but we do want to energize our workforce and to ensure that they have the best opportunities so that we protect this subject area, which is often challenging, and that they feel they're getting something from it. So once again, thank you very much indeed. Obviously, thanks to the charity that I run for supporting this, and Go Girls actually supported the publication of the BGCS nursing competencies, which fulfilled our charitable objectives. And as I say, that's why we were very delighted to be able to help support today. So Amy, that's me, done, dusted. Everybody can run and get their trains now.
Thank you so much, Hilary, for that whistle-stop tour of the BGCS nursing competencies. Did anybody have any questions? Just one, no?
Thank you very much for that, Hilary. Are the competencies going to outline what is required for RCNSs in terms of breaking bad news clinics?
Well, that's a very, very interesting point, actually. And that is going to form part of part 2. That's something that I've discussed with my colleague Helen. And it's something that I've actually been taking soundings about, because without doubt, certainly my contemporaries in other specialities, they run breaking bad news clinics. Now, where I work at the moment, there's a lot of resistance to that. And I think it would be quite interesting to perhaps have a little straw poll, perhaps something I could talk with Ranjit about, possibly getting a feel for the room in terms of how many clinicians feel that it would be appropriate for clinical nurse specialists to undertake that. I mean, I think for me, in terms of us who, I would say continuously every day, I'm delivering very difficult news in one form or another.
Should we do a poll of the
you know,
people who are here? Should we do a hands up?
Yeah, that would be really helpful, actually.
So, of the people here, who would be happy for their CNS to be doing Breaking Bad News clinics? It's maybe 2/3, maybe as high as 3/4. So I would say the majority of people in the room who are left, the hardcore group, would support our CNS team do that. Would you?
I suppose the interesting converse question, Amy, is why do people feel they wouldn't want them to do it? Because I think if we don't understand why they wouldn't want us to do it as clinical nurse specialists, we will never make progress. So if we don't understand what the barriers may be, and I'm sure those who are not keen will of course have some very valid reasons, but if we don't ask everybody what their opinion, so it'd be very interesting would somebody be willing to volunteer to say why they don't want to do it.
The people who did not put their hands up, would anyone like to say what their reluctance or hesitancy would be in CNSs doing Breaking Bad News?
Yeah, this is actually a little bit challenging, this question, I think. I think I don't have so much a problem with the CNS breaking the news. I feel more for myself that if I've started something up with a patient that I would like to round it off. So maybe it is more for myself than for the patients, if I'm honest.
Do you think that's sort of the way in which we're cultured in terms of our training, so that therefore, the clinician, without doubt, and of course we respect this fully, is obviously taking, in inverted commas, ownership of the patient and is therefore accountable and responsible ultimately. But bearing in mind, I feel CNSs are obviously independent practitioners, and I feel I work very closely with my clinicians. There's something I don't know or I want advice on, I'm always obviously going to send them a message to say, I want your input. You are the expert. You are a senior to me. I respect that. So therefore, I want your input. And bearing in mind the number of dialogues we have about various aspects of their care, which is all day, every day, do we need to just think outside slightly traditional models? Any other thoughts?
Yeah, in a way I agree with that. I think the way we do it at the moment is that we sit with the CNS when we break the bad news, and that we then split. So we do it more as a joint thing, which I think is the nice way to do it.
Which is what we do. They spend a couple of minutes with the consultant and then an hour with me. So by which time they've, obviously the first few minutes, inevitably, if you're giving anyone any difficult news, no matter what it is it? You're left a bit shell-shocked. So the time we then give them is reiteration, information, answering questions, just allowing them the space to talk. And then we follow it up with a health needs assessment clinic, and then we start their sort of support journey. So we have quite a process to that. And I suppose it's just whether you can wrap the whole thing up with the CNS at the outset. But, always very happy to hear what people have to say and take all of that on board. But it is something we've certainly looked at as part two, as a more advanced skill.
Oh, thanks, Hilary. I think for me, the reason why I would prefer as the clinician to break bad news is that rapport. The patient, I think, ultimately, if the treatment is hysterectomy or surgery or whatever, they might want to ask more questions about that. But it's that rapport of, okay, I've seen who the surgeon is. And to me, that is where I would prefer breaking bad news along with my CNS colleague, because rather than just leave it to the CNS colleague, is that rapport. You're going to surgery. Who is my surgeon? I haven't met the surgeon yet.
But I suppose there'll be quite a proportion of patients who may move on to another centre where they've not met that surgeon, because it's going through MDT. I absolutely take your point, and I think it's a very valid point, absolutely. Is there an element of also trust with the patient, feel that they are getting a second-class service, because they themselves also will have a traditional formulation of a model in their head. So I think it's something that needs more discussion. That's my view. I'm not completely opposed to it. I believe our tandem approach works very well at the moment. But I suppose it's like all things, isn't it, in medicine, and as time pressures and more demands get placed upon us, whether that is something that needs to be rethought in the future. And I suppose for me, I always like to keep an open mind. It doesn't mean to say that I'm right at all. That's not what I'm saying. But I like to keep an open mind, and I think it's always healthy to have debate about, more complex, tricky subjects, because that's how we grow, learn and develop, really, which is how we got into the establishment of having gynae-oncology competencies, because they become the foundation stones for practice. And then we're developing part 2, which is enhancing that knowledge to enhance the practice, as well as trying to keep nurses feeling valued and part of things, really. So I think there's it's complex, isn't it? So it's really interesting to have your views. So I really appreciate that. Thank you.
Thanks, Hilary. I'm going to go back and ask my CNS if they'd want to. My concern would be that my CNSs already feel overwhelmed with the amount of work they already have to do, and I think particularly with the genetic stuff that's coming in, with the Lynch
That's taking
stuff,
up an enormous amount of time.
and
Huge amount
triage.
of
Some
time.
of them are doing triage as well, and I think that they're already starting to push back a little bit on who they come and see with me. And I think if I said, "Oh, do you want to do a bit of Breaking Bad news as well?" I think I know what the answer would be, but I'd be very happy to ask them. They also
You'd be
some
off
of
the
them,
Christmas card list.
yeah, I think they also do quite a lot of the follow-up now. I think that's slipped into a lot of the CNS role. So I think the role is hugely diverse, and I think these are also really busy people. But it's good to ask the questions. Did anybody else have any other questions for Hilary before I end the session? One more. Joe's got one more, and then I will wrap up.
Sorry, Hilary, it's a quick question about these competencies. We've got a new CNS in our unit training. Is this like the competency for them as a guide, or is it for like other general nursing that we are trying to inspire? Am I correct to say this is to guide them?
Specific to gynae-oncology. So it is a gynae-oncology competency package. So, for example, my new associate CNS, she's not worked in oncology before. She has limited gynecology experience, not zero or anything like that. And she's a very competent nurse. So it's really taking somebody right from the ground up to be working up through 3 domain levels across 5 gynae-oncology areas in an incremental way. So I've started her on endometrial because obviously that's the highest numbers. Then she's going to do ovary and then move on. And so we've looked at the timelines in relation to that. So she's going to spend about 6 months doing each. One of the ones she's sort of, as she's starting to pick up her own speed, of course, with learning, she's starting to get more familiar with what she should do. And then obviously I set regular reviews for her, try and help support her and signpost her for more learning. And then obviously she gets more competent in her knowledge. I will obviously expect her to be perhaps doing a little bit more in-depth research, but help guide and support her in that process. But equally at the same time, I don't want to put her under phenomenal amounts of pressure, because I listen and I totally take Amy's point. We are all working very, very long hours, but I do give her 3 hours study time a week to do this. So I am being quite generous for 2 years. Now I'm happy to do this because I really want her to succeed in her career. And when I've moved into my coffin, I expect her to be able to take my lead. So I want a lovely, fully formed person, but somebody who's also very interested in the subject matter and who may also want to go and inspire other generations herself. So, it's kind of like a sort of building block, isn't it? It's building a house and trying to get her to put the roof on and then light the fire up the chimney and send the smoke off and move it forward into another country and so forth. It's sort of iterative to becoming a progressive document and a growing document, a dynamic document, which is why we're moving on to part 2, because we know it can take us a little while to construct it, just because of our own constraints and our time.
Thank you so much, Hilary. I'm honoured no microphone again. Thank you, Hilary, for your time, and we all wish you speedy recovery, and hopefully we'll see you next time.
Day, so I do apologise, everybody. I was so looking forward to being there in person and seeing everybody. So I'm sort of limping on, but I just felt the travelling was perhaps just a little bit too much at the moment. So thank you again, and thank you for inviting me. Have a lovely weekend, and all the wishes to you for Christmas. I'll sign out now. Thank you. Bye bye.